Thank you everyone for joining us to the webinar on the theme Updates in the Management of EGFRm Non-Small Cell Lung Cancer. Without wasting any further time, it gives me great pleasure to introduce our organizing chairperson, Dr. Shyam Aggarwal, Senior Consultant, Department of Medical Oncology and Bone Marrow Transplant, Sir Ganga Ram Hospital, New Delhi, to please give the opening comments. Over to you, sir.
Good evening, everyone, and thanks to ICON and the organizers for giving me this opportunity to discuss this important subject of EGFR mutated non-small cell lung cancer. So I think, as we all know, EGFR mutation has really led the way we understand non-small cell lung cancer, particularly adenocarcinoma. And it really has helped the molecular biologists, the clinicians, and the patients to really pave the way for targeted therapy in adenocarcinoma. And it, as I say, it actually is leading the way we are now beginning to dissect the differences between presentations and outcomes for different exons. Whether they are common mutations in exon 19 and 21. So those differences are now beginning to unfold. But yes, we already knew exon 20 is different. Then of course the uncommon mutations behave differently. And then the evolution, when they come under pressure of the TKIs, and then the emerging role of doublets in the management of EGFR mutated non-small cell lung cancer. And I think that the biggest achievement as it is unfolding is the availability of next generation sequencing, not only in the tissue, but I think the liquid biopsy, which is evolving so very rapidly, is also going to help us in understanding how the tumor biology unfolds and how do we treat a patient, one after the other in a sequential fashion. So I think we have three important lectures. It's a little crowded evening, followed by a panel discussion. So I won't stay between you people, and I'll, like you and we have the program director, Dr. Ullas Batra from Rajiv Gandhi Hospital, who is also going to moderate the session. And we have the invited international speaker, Dr. Rosario Garcia from INIBIC, Spain. So I welcome you all. And after these few words, I hand it over to the organizers to invite the first speaker. Thank you very much.
Thank you so much, sir. It gives me great pleasure to introduce our first speaker. Our first speaker is Dr. Navneet Singh, who's a senior medical oncologist and pulmonologist and currently professor in the Department of Pulmonary Medicine at the Postgraduate Institute of Medical Education and Research, Chandigarh. And he'll be talking on the topic molecular biomarker testing in lung cancer. Over to you, sir.
Thank you, Kashish, and thank you, Dr. Shyam and Ullas, for inviting me for this lecture. So before I begin the customary things, is my screen visible?
Yes, sir.
All right. So the topic assigned to me is molecular biomarker testing in lung cancer. So I have no conflicts of interest, and I'll try to discuss this under the headings: what to test, why test, whom to test, and when to test. So coming first to what to test. So earlier the answer used to be simple, 2 decades back, nothing. And between 2001 to 2004, it was really about EGFR protein overexpression by immunochemistry, and then came in EGFR gene copy number by FISH. Then the next 4 years or so, a little bit of EGFR gene mutations came in, and the method was sequencing. And by 2009, it became clear that it was only the EGFR mutations which really mattered, and not the other two things. And of course, the method improved over the next 4 years to real-time PCR, or the ARMS PCR, what is called. And thereafter became the advent of NGS. Now, what one needs to remember that whatever happens in North America, Europe, or East Asia, it takes time for all of that to occur here and get applied into clinical practice. And the same is true not just for EGFR, but for the other things as well. So till 2009, it was just EGFR mutations. Next 4 years, one had to look for ALK rearrangements, then came in ROS rearrangements, then came in PDL1 and BRAF mutations. And after that, it's almost 10 targetable oncogenic drivers. So if you talk about our context, what is the basic minimum which one has to do despite substantial resource constraints? I would like to emphasize that it has to be EGFR mutations by real-time PCR and ALK rearrangements by IHC using D5F3. That is no matter where you are in this country or in the world. What is preferred if you have some resource constraints? I would add PDL1 expression by IHC using SP263. What is ideal with minimal or no resource constraints? Well, one would do NGS for EGFR as well as for all of the other targetable oncogenic drivers. I would also advocate testing ALK separately with IHC and maybe even ROS by FISH and PDL1 using both the methods which are used to determine to use whether to monotherapy or the combination with immune checkpoint inhibitors. But resource constraints are not the only constraints. Tissue is another common limiting factor because most diagnoses are by small biopsies and FNACs. So pathologists need to use the tissue to do the microscopic examination and in most cases immunochemistry to confirm diagnosis of lung adeno. But one has to remember to ask the pathologist and the interventional radiologist to make cell blocks if doing an FNAC instead of a biopsy. A good cell block is as good as a small biopsy for all purposes, including immunochemistry and molecular testing, and I'll come to that a little later. The question number 2 is why to test? And I think words speak better than 100 words or 1,000 words. So as you can see, this is a patient with metastatic NSCLC with EGFR mutation, started on a first generation EGFR drug. And if you are monitoring by chest radiographs, you can see there has been remarkable improvement. If whether you go by CT scan monitoring also, again, another EGFR positive patient on a second generation drug, afatinib, done excellent when you repeat a scan, and this is at 7 months of treatment. If you look at ALK, this is another patient, 9 months on the first generation drug, crizotinib, excellent responses again. And even if for any chance you were to do PET scans, and you can see this patient who has been treated with a second generation ALK inhibitor, osimertinib, using a 450 milligram with low fat meal concept, remarkable improvement. And last but not the least, if you have a metastatic NSCLC with a high PDL1 and an NGS negative, you can see the baseline scans on the top, and again, almost complete improvement with 3 months of monoimmunotherapy, which is pembrolizumab. Well, and last but not the least, you can see that if even patients who have comorbidities, for example, a DVT PTE in metastatic NSCLC and who's ALK positive, 6 months of alectinib treatment does wonders. The more important thing is that to be able to pick up an oncogenic driver and give the appropriate targeted therapy, because that is what really makes difference in improving survival as compared to either having no driver or having a driver but not getting the appropriate targeted therapy. So the answer to question 2 is pretty much very simple. This is the era of precision oncology and biomarker guided treatment strategy, which is likely to be the most effective and the cost effective. And obviously you will hearing more about the real drugs, but anybody wanting a quick reference can refer to these ASCO guidelines, for which I was honored to be part of them. Question number 3 is whom to test. And again, I was part of these ASCO guidelines on molecular testing, and basically these were for advanced lung cancer, stage 4 or other unresectable disease. So the important thing is it doesn't matter whether the sample is from the primary lesion or metastatic lesions, they will do just as well. All adenos should be tested. Any non-squamous NSCLC histology should be tested, or any non-small cell histology in which clinical features indicate a higher probability of an oncogenic driver, for example, young age, light, or absent to macro exposure. And importantly, you can use either cell blocks or smear preparations as suitable specimen based upon the content, which should be at least 20% cancer cells. And as you can see, examples of report at our center, this is on the left is an L858R detected on a biopsy specimen, but on the right-hand side, you have another cytology specimen in which an exon 19 deletion has been detected. And similarly, again, a cytology sample in which ALK has been detected by IHC testing. And just to go a little more into this thing, our 10-year experience shows that majority of the patients are males as 2:1 compared to females. Non-smokers are lesser than the current or ex-smokers in terms of molecular testing, and it is largely or almost exclusively driven by adenocarcinoma, 95%, and the stage 72% is stage 4 for these patients tested, as one would expect. Now, exon 19 deletions to L858R, the ratio is 2.8:1. Male to female is almost equal, but if you look at this chart, you would see that for the uncommon mutations, it's actually more dominant in males as compared to females. I don't know the exact reason. And if you were to depict this diagrammatically, again, exon 19 deletions the most common, approximately 2/3, followed by the L858Rs in approximately 1/4, and then you have smaller chunks with exon 20 insertion 5%, T790Ms at baseline 4%, L861Q 3%, and so on. But the important thing is that the positivity rate is approximately 25% for EGFR and almost 10% for ALK. And there is a significant age difference. And as we have moved from sequencing to RT-PCR for EGFR, and from break-apart FISH to IHC for ALK, the percentage of interpretable samples has gone up significantly, as you can see. The other important thing is that there are significant differences between the distribution of positives versus negatives, again, dominating in females, non-smokers, based upon the testing method, and obviously metastatic disease. And that is true for both EGFR and ALK. But if you look at it in a little bit minutely, as you can see, overall EGFR prevalence around 26%, ALK around 10%. If you restrict this to only adenocarcinoma histology, it goes up slightly higher, 28% and 10%. You restrict this to females and adenos, it's 41% and 16%. And similarly, if it's for females and non-smokers. Even for males, non-smokers, it's approximately 33% and 15%. And male smokers, 16% and 4%. So believing that these are mutually exclusive for most purposes, you can see overall approximately 1 in 3 patients should have a targetable oncogenic driver amongst EGFR and ALK. Adenocarcinoma 2:5, female adenos or female non-smokers more than half, and males non-smokers reaching close to 50%. Male smokers still 1 in 5 would be able to get the benefit of targeted therapy. Last question is when to test. So preferably at initial diagnosis, one has to make attempts continuously, even if the initial tissue is inadequate, and one could do either rebiopsy or liquid biopsy. Definitely on progression, which is the current standard for EGFR mutated patients, in future perhaps for the others as well. In stages 3 or less, it's not mandatory but preferable, and this is largely driven by EGFR. The same is true for the adjuvant setting as well. In small cell and squamous, not recommended as of now, barring situations that mandate ruling out an occult adenocarcinoma component. And our analysis of liquid biopsy is similar, that its utility is very good when you are doing for EGFR mutated patients progressing after first or second generation drugs. Well, in 2019, nobody knew that the future was all going to be about COVID-19. We didn't even know in 2020 that 21 is going to be the same way. And even for this early part of the year, it has been something like that. However, for the future, for lung cancer, it's a different story. We now know that liquid biopsy can be used for several things. And amongst the ones which are highlightable is you can do PD-L1 expression in circulating tumor cells. This was a paper late last year, and it was correlating with the immunotherapy efficacy. Also, what came across was that the initial enthusiasm for TMB seems to have gone. This was a paper in ESMO, the Annals of Oncology, which showed that it is not really TMB which matters, which is its correlation with CD8 and neoantigens. And apart from that, TMB made no difference. And lastly, one knows that PD-L1 is the most important biomarker for immunotherapy. However, we need to realize that there are individual gene alterations which determine the response for immunotherapy in addition to PD-L1. And this is all going to become an increasingly complex story as the times go by. And this is going to be the genomic and proteomic landscape of lung adenocarcinoma in the times to come. And so with that, I'd like to end my talk. Thank you so much.
Thank you so much, sir. We'll move on to our next topic. The topic is experience sharing in the management of advanced EGFR mutant non-small cell lung cancer patients. And I invite our international speaker, Dr. Rosario Garcia Campelo, who is the head of the oncology program at University Corona at Spain. So ma'am, can I request you to please give your talk? Over to you, ma'am.
Sorry? Yeah, can you see
sorry,
my...
Yes, ma'am, we can see your slides.
Yeah, okay. Okay, good evening, everyone. Thank you so much for joining us today. It's a great pleasure and a great honor for me to share this session and this time with all of you. Hopefully, we will have a very fruitful and active discussion. We're going to talk about one of the most relevant aspects in the field of non-small cell lung cancer. It has been mentioned, EGFR was the very first one. And I think it was a completely change of the way we used to do things in lung cancer. We have a new culture, we have a new way of doing things, and I think it has been really relevant. Just to tell you where I am based. I am based in the northwest of the country, or the northwest of Spain, in La Coruña. It's a very nice city. And one of the most relevant places in the city, you can see in the slide, we have the Hercules Tower that has been declared a World Heritage Site. We have also the largest promenade, urban promenade in Europe, almost 30 kilometers all around the city. You can enjoy, I would say, the best seafood in the country in our harbor. And also, I really recommend you to come and see the city of Santiago de Compostela, a very old city, a wonderful city where I have the opportunity to do my medical educational program. So for me, EGFR is a very special history. I have the great opportunity to be in Boston, in Harvard in 2004 as a young investigator. I was finishing my residency, and there it was also Dr. Pasi Jain as young investigator. But in that meeting, in that course, he saw us the paper he was almost ready to publish with this amazing discovery, the EGFR mutations and the correlations with EGFR tyrosine kinase inhibitor response. For me, Dr. Pasi Jain is one of the biggest medical oncologists in the field of lung cancer. And when I think about EGFR, I always remember this nice opportunity. He came to Madrid a few months ago, and we also had the opportunity to meet again. Since then, many things and increasing knowledge on the field. We know that EGFR mutations can be a heterogeneous subgroup of patients. When we talk about this alteration, we usually try to talk about the common sensitizing mutation, SO19 and 21. We know that the epidemiological differences according to the area you are based on, like the high incidence of this alteration in the Asian population is less common in the European population. We know that it's always most commonly described in women and never smoker. But again, I think that all the knowledge is getting complicated. These are good news. And thanks to the NGS approaches, we know much better this specific genetic alterations. And it has been said, we have the new target, new kid on the block, exon 20 insertions, and we also have the atypical EGFR mutations and the complex EGFR mutations. We know for sure that we should treat these patients with a targeted therapy. We know that we can improve the outcomes. This is the probably the most important aspect of this talk. Tyrosine kinase inhibitors are the standard of care, and they should be used at the very beginning. Not all tyrosine kinase inhibitors are created equal. We know that this disease is, we are attacking a moving target, so we need to do a close monitoring of the disease in order to offer the best treatment approach. Again, this is good news. We have more options, we have more opportunities, but also more dilemmas. I really like the concept of sequencing approaches, but the truth is that today we have very potent agents that we can use from the very beginning. And according to the guidelines, we can use first, second, or third generation EGFR tyrosine kinase inhibitors from the very beginning, although it's true that NCCN recommend Osimertinib. Also, some combinations have been included in the ESMO guidelines and also in the Spanish lung cancer guideline, like erlotinib or plus bevacizumab. We also can discuss the value of this combination a little bit later. So, what is the main aspects we based our decision? Well, I think that all of us as medical oncologists, we really like evidence. And when we decide to apply for a specific treatment, we always look for activity in terms of systemic activity, brain activity, but we also take into account quality of life. We are talking about advanced non-small cell lung cancer patients. We are not curing the vast majority of this population, so quality of life matters. Toxicity is very related to quality of life. I don't know in your country, but in my country, cost is a relevant element for decision. So let's review very briefly, because I already know that you are aware of this data. The new one, the FLAURA trial and the Osimertinib. Let's start from the end of the story. As you already know, the FLAURA trial is a very well done phase 3 trial comparing Osimertinib versus a conventional first generation tyrosine kinase inhibitor. The primary endpoint of the trial was progression-free survival. Around 20% of patients had brain metastasis at baseline. This is something that we need to take into consideration when we do cross comparisons among trials. The vast majority of the patients who receive a standard of care receive gefitinib. And this is important also when we talk about how we manage these patients in our daily practice. 70% of patients in both arms continue the tyrosine kinase inhibitor beyond progression. I really like also the concept of treatment beyond progression. These are the main patients' characteristics. I think the most important aspect here is that around 20% of patients have brain metastasis, and this is the primary endpoint. You already know that this is a very positive trial with a very relevant difference in terms of median PFS, almost 19 months compared to 10 months, has a ratio of 0.46. When we look at the forest plot, we can see that all patients get benefit from the approach with the third generation tyrosine kinase inhibitors. This is also something that I don't think is surprising us. Patients with exon 19 deletion do better compared to patients with exon 21. But again, the difference is relevant for those patients receiving Osimertinib compared to the standard of care. As I mentioned, around 20% of patients have brain metastasis. Any differences? Okay, I can say that the message is quite clear. The activity or the benefit of Osimertinib is maintained despite of the presence or absence of CNS metastasis. Duration of response is also important. It's not only that patients achieve responses, how relevant is that the response, the quality of that response, the duration of that response is really, the difference is really significant. And looking at survival and taking into account the crossover, I think the data is really positive. We can see significant differences in terms of overall survival, favoring the use of Osimertinib compared to EGFR tyrosine kinase inhibitor first generation. As I mentioned, most of the patients receive gefitinib. And here again, the situation for the different subgroups of patients. Well, when we think about osimertinib, I think it's a great agent. Usually we try to think in these new agents, potent agents, and relate this potency with the activity at the brain level. I think this is important. This consideration is really important. And why is it so important? We know that brain metastases are a real problem when we talk about advanced non-small cell lung cancer. The percentage of patients with brain metastases is increasing. And I think that the main reasons are that our patients today live longer. So the period of time and the risk of developing brain metastases is increasing. And also I think that we are using more CT, brain MRI, and we are detecting more asymptomatic brain metastases. Specifically, when we talk about this issue, brain metastases in patients with genetic alterations, clearly it seems that patients harboring brain mets, EGFR mutations or ALK translocation, for example, they have a higher incidence of brain metastases compared to the wild type population. So we need also to consider the assessment of the brain at the very beginning, even if the patient is asymptomatic, because I think this is something that is really frequent in patients with oncogene genetic alterations like EGFR, ALK, or ROS. The good news is that when we try to incorporate this genetic assessment in the GPA scoring criteria, those patients with EGFR or ALK translocations do better when we incorporate this scoring system. And again, I think that the main reason is that we have potent agents that can be very active at the brain level. Again, the guidelines, NCCN and ESMO guidelines, and talking about central nervous system guidelines, they recommend in patients with EGFR sensitizing mutations and ALK translocations, in those with asymptomatic, specifically the ESMO guidelines recommend in those with asymptomatic CNS metastases, at presentation, radiation should be deferred and a systemic therapy should be initiated. We may also discuss if we agree or not agree with this recommendation in our daily clinical practice. How active are the EGFR tyrosine kinase inhibitors at the brain level? The main problem we may have with the first or even second generation ALK inhibitors is that usually we are talking about all trial retrospective data. In the data we have come from a small series. The agents are active, but when we look at the FLAURA data and we look at the CNS activity in the FLAURA, really we can see a difference. If we focus on those patients with CNS that are available for response, response rate is 91% for those receiving osimertinib compared to 68% for those receiving the standard of care, the conventional EGFR first generation tyrosine kinase inhibitor. And again, progression-free survival for those patients with brain metastases has a rate of 0.47, 15 months for those receiving osimertinib, 9.6 months for those receiving a standard of care. And it's not only that the agent is active at the brain level, we can see the response rate, we can analyze the PFS. It's also this kind of a protective effect at the brain level. And I think this is really relevant when we talk about advanced non-small cell lung cancer and how negatively impact the development of brain metastases in terms of prognostic, but also, really important, in terms of quality of life. Well, we have started with osimertinib. I don't play golf, but I have many friends who play golf. And I think this is something very common for those who are used to golf. If you hit a hole in every hole, you wouldn't play golf for very long. So one of the main arguments is that if we use osimertinib from the very beginning, maybe we are losing opportunities to do this kind of sequencing approach. Well, let's try to see what we can get from the first and second generation EGFR tyrosine kinase inhibitors. The very first trials compare these agents to conventional chemotherapy, positive trials in terms of progression-free survival. We are talking about 11, 12, 13 months of progression-free survival for those patients receiving the EGFR tyrosine kinase inhibitors. When we did comparisons, and we have the LACLAN 7 trial, the Archer 1050 trial, DACO versus GEFI, and the FLAURA. We already commented the FLAURA trial. The truth is that, again, the three agents, second afatinib, second dacomitinib, third generation osimertinib, the three agents are really active. But it's clear that osimertinib can improve progression-free survival numerically. And I also think it's important to understand the morphology and the shape of the curves. The improvement in the FLAURA trial comes from the very beginning, while in the LACLAN 7 and Archer trial, it comes after around 6-8 months. We shouldn't forget that in the Archer trial, patients with brain metastases were not allowed. So again, the trials are different, the drugs are different, and these are the results we have so far. And if we look at the OS, at the overall survival, and we analyze the different data we have with first, with second, and with third generation, clearly, we have, I would say, a winner. I don't know if maybe like the ABBA used to say, the winner takes it all. We need to analyze also the toxicity profile. Compared to chemotherapy, I think that these agents have a very mild toxicity profile. When we look at the second generation tyrosine kinase inhibitors, I think that the most relevant aspect, negative aspects in terms of toxicity are related to gastrointestinal and cutaneous toxicity. Those adverse events are less frequent in those patients who receive osimertinib. And regarding quality of life, again, we are comparing very good agents. First, second, third generation, all of them have a positive impact in terms of quality of life, although the relevance of the difference are not so important. No? So at the end of the day, we need to focus on, and we need to make a decision in our daily clinical practice. And as I mentioned, if efficacy was one of the relevant elements for decision, we have PFS, we have OS, we have duration of response, we have this kind of protective effect at an intracranial level, and we also have a very moderate toxicity profile. So I think that it makes reasonable that osimertinib is one of the best options in the first-line setting. Well, having said that, I think that we are not doing enough, okay? These drugs have done a wonderful job and have opened a new way to treat and to understand this disease, but we need to improve the current outcomes. And one of the main issues I have is, can we improve the results we have so far from the very beginning? It's clear that there is no single EGFR mutant patient that is equal to another. So how can we do it? One approach that has been tested in different trials is the combination of an EGFR tyrosine kinase inhibitor plus an anti-angiogenic agent. This has some very preclinical rationale, and the data coming from phase 2 and phase 3 trial, well, seems at least promising. We have PFS around 17, 18, 19 months, but unfortunately, no important differences in terms of overall survival. Very recently, also, we knew the results from this trial coming from Asia, osimertinib plus beva versus osimertinib in the first-line setting. And when we look at the results, we see that the difference is not so high in terms of progression-free survival, no differences in terms of overall survival, but looking at the subgroups, and specifically those patients, those smoking, those patients who have smoked, the combination seems to be very convenient. Is this observation enough to offer this kind of approach to a patient harboring an EGFR mutation? In my opinion, I think it's not. I understand that this approach, EGFR plus anti-angiogenic therapy, has a role, consistent biological rationale, but it's more toxic. We need to consider if patients can receive an anti-angiogenic therapy. We are introducing the IV infusion, and patients love, at least in my experience, love the concept of oral therapy. We are increasing the cost of the treatment. But again, looking at the results we have seen in this recent trial and also in the trial we developed here in Spain with the ETOP group, it seems there is some kind of signal in those patients who have smoke and have an EGFR mutation. So maybe this needs further investigation. Another approach is, use a tyrosine kinase inhibitor plus conventional chemotherapy. And we have two very nice trials showing that this approach can be very useful and in terms of progression-free survival, but especially in terms of overall survival. I think this is something that, of course, is being investigated. I think I have the trials here. And this approach of combining a tyrosine kinase inhibitor plus conventional chemotherapy, again, has consistent biological rationale. We have seen the results, very promising improvement in terms of progression-free survival and overall survival. If we use a first generation plus chemo, we still have place for Osimertinib in the second-line setting. Again, we are introducing the IV infusion. It's higher cost, and we need to consider patients' quality of life and patients' preferences. But as I mentioned, this approach is being investigated in the FLAURA2 trial. It's a phase 3 trial that is comparing Osimertinib plus chemo versus Osimertinib in the first-line setting. And there is another approach, the Mariposa trial. We are participating in the Mariposa trial. It's a trial that is testing in the first-line setting Lasertinib, a third-generation EGFR tyrosine kinase inhibitor, plus amivantamab, a bispecific antibody anti-EGFR anti-MET, Osimertinib, and Lasertinib monotherapy. So we are trying to improve the current results in the first-line setting, exploring other ways, other potential combinations. But again, I think that we are missing something here. We need to define who are the patients that are getting the strongest benefits with monotherapy, and who are those patients who could benefit from this kind of combination approaches. And I think the biology of the disease is giving us the answer to this relevant and important question. NGS has allowed us a growing knowledge. We know that EGFR mutation is not that simple. Patients can have concomitant alterations like P53 or STK11, P10. So, and we even know that patients with the P53 mutations do worse. P53 plus EGFR mutation do worse when they receive conventional EGFR tyrosine kinase inhibitor compared to those patients with EGFR mutant and wild type P53. So probably these patients need a different approach. I don't know, the combination approach with chemo, the combination approach with anti-angiogenic, but clearly we are talking about different populations. It's not only what is happening at the very beginning, it's trying how the disease is responding to the pressure you are giving to that tumor. And for this, I think that liquid biopsy is going to be really, really important. We have some data coming from different experiences, most of them retrospective experience, showing how those patients with ctDNA clearance after exposures to a specific EGFR tyrosine kinase inhibitors do better than those patients who do not achieve this kind of ctDNA response. We have the same message from the FLAURA trial. So again, it's not only that patients are different from the very beginning, it's that patients we can monitorize those patients under a specific treatment, and we could, and I think this is a very nice proposal, we could modify the treatment we are offering to our patients according to this active movement of the tumor cells. For example, we started an EGFR tyrosine kinase inhibitor, no drop in ctDNA. We can compare chemotherapy plus tyrosine kinase inhibitor or continuation of tyrosine kinase inhibitor. The APPLE trial we have finished here in Spain and also in the ERTC group is trying also to see how useful can be the ctDNA trying to offer different therapeutic proposals, or how can be integrated in our daily clinical practice to monitorize and to make clinical decisions according to ctDNA analysis. Well, I truly believe this is a great story, but we need to check our enthusiasm. Unfortunately, we are not curing our patients. We are getting significant and very promising results. Our patients live longer with better quality of life, but the concept of cure, we are far from the concept of cure. And I really like to remember this quote from Paul Kalaniti, who was a physician with lung cancer. I think it's something that we need to remember when we talk about this kind of oncogenic defined population. Every day brings me farther from the low of my last cancer relapse, but every day also brings me closer to the next cancer recurrence and eventually death. So with this in mind, we need to try to figure out the whole picture. So we use the best approach from the very beginning, and then what? This is a very, very recent publication. I really enjoy this publication, and they analyze different situations, and specifically when they talk about the management of progression after osimertinib treatment, they divide in local progression and systemic progression. If it's local, they recommend local therapy plus osimertinib beyond progression. If we are talking about systemic, they strongly recommend rebiopsy, liquid versus tissue versus both, and try to figure out what is going on. It's a histological transformation, what kind of resistance mechanism, and they do some recommendations according to the different situations you can find after doing rebiopsy, after doing molecular analysis, that we can also discuss how feasible, how easy or difficult is to do this in our daily clinical practice. Why is so important to understand what is going on? Well, we know that resistance mechanisms have been described. They are not exactly the same after first or second line osimertinib. MET amplification is one of the most frequently found after first line setting osimertinib, but also RET fusions, BRAF, KRAS mutations have been described. If we cannot offer any specific therapeutic approach according to the resistance mechanism, this recent paper recommends us the use of conventional chemotherapy, and we can discuss if this chemotherapy should be with immunotherapy plus minus an anti-angiogenic agent. We have data from the IMpower 150. We know that the combination of chemo plus immunotherapy plus beva can be useful in patients with EGFR mutation. I think these results open the opportunity to investigate much more if this is really useful for this kind of population. I have tried this combination in several patients. My experience is good, it's limited, but it's good. And also very recently, another trial was presented by Suris Gadel. And in this case, in patients who progress after a tyrosine kinase inhibitor, they offer a platinum-based chemotherapy doublet plus immunotherapy without anti-angiogenic agents. So the results they get in terms of progression-free survival and overall survival are really also promising. And the key question is the anti-angiogenic agent essential when we offer this kind of combination approach? And for me, the best approach is this kind of proposals. We are participating in the ORCA trial. Those patients who receive osimertinib in the first-line setting, after progression, a tumor biopsy is required. And according to the type of resistance mechanism, patients are offered different proposals, therapeutic proposals. The truth is that it's not an easy trial, but as I mentioned, I think this is the way to move forward in this field of EGFR mutant population. 2 slides just to summarize the situation of EGFR uncommon mutations. We know that this is a field that is growing, the knowledge is growing. And again, a very nice review by Antonio Passaro. We have data, the strongest data we have come from the studies with afatinib. And also we have a trial from Korea with osimertinib. And in fact, the clinical guidelines have included afatinib or osimertinib as first-line agents in the first-line therapy for those with uncommon EGFR mutations. So, very last messages. There is a lot happening quickly in the EGFR mutant non-small cell lung cancer field. The truth is that we have improved the outcomes over the last years, but we are far from cure. I don't know if this is this should be our goal, but as I mentioned, I think we are far from cure. Frontline osimertinib is the preferred first-line treatment today after showing superiority in terms of progression-free survival, overall survival, and a very good toxicity profile. Hitting the target harder invariably leads to further hard to treat on target mutations of target resistance. And I think that clinical trials is the only way to try to validate potential options in those patients who progress after osimertinib. Cancer cells are active players in the game. I truly believe that the dynamic evaluation of the tumor is going to be necessary to anticipate subsequent cancer cell movements, our movements, and of course, ctDNA, NGS, tumor NGS is the best way to anticipate the movement. We can do it, I don't think we can do it alone. I think that this needs to be done in multidisciplinary approach, where everybody needs to believe that it's really the way to move forward. I don't know if we have some time for 2 quick cases. I would like to ask the organizers.
Sure, ma'am.
I really don't know if we...
Please go ahead. Yes, ma'am.
Okay, very, very quick. So the first one is a 79-year-old male, never a smoker. In December 2019, he was diagnosed of a non-squamous advanced non-small cell lung cancer, exon 21 mutations. He was included in the APOL trial, and he was allocated to the osimertinib arm. He achieved a very nice partial response with very nice, no significant adverse events, 18 months receiving osimertinib. He progressed at lung, mediastinal lymph nodes, and bone. And we decided to do an EBUS, and adenocarcinoma was confirmed. The presence of exon 21 mutation was also confirmed. And we found a MET exon 14 mutation, not a MET amplification, a MET exon 14 mutation that is really rare. So I think we still have a lot to know about these cases. We applied for the combination of osimertinib plus carmatinib. It was approved by our hospital. The patient received this combination for only 3 months. He again the disease again progressed, lung, mediastinal, and bone. And in January 2021, 1 month ago, again, a liquid biopsy was proposed. In this case, more than 360 methodology. And again, we had some information of from this liquid biopsy, the presence of exon 21 mutation and the presence of C797S mutation. So we decided to start 20 days ago gefitinib. The truth is that I don't have the radiological assessment because it's too soon, but I can tell you the patient was symptomatic with pain, with a shortness of breath. The patient is doing great. I really want to look at the CT scan because I think this patient is getting response with gefitinib, but again, I have to wait for the CT scan. But clinically, the improvement is very significant. So the truth is that with these cases, we have to study. We really don't know many things in these cases, but this, as I mentioned, I think this is the way to move forward. And the other case is a 73 years old female, never a smoker, exon 21, plus T790M mutation, basal concomitant alteration. This patient was included in the FLAURA trial. She again had the opportunity to start Osimertinib in the FLAURA trial. She was receiving Osimertinib for 21 months, no relevant toxicities. She progressed at the lung bilateral nodes. We do a pulmonary biopsy. The pulmonary biopsy confirmed that no exon 21, no T709 mutation was detected. And we did see the transformation in a small cell lung cancer. We started platinum plus etoposide, 6 cycles, partial response, but unfortunately the patient progressed. We did again liquid biopsy. This time we detected the T790M mutation, and we decided to try to analyze or to confirm the results with the more than 360. No, sorry, we start erlotinib plus Avastin for 4 months, again progression, and we did a Guardian analysis at this time of progression. Exon 21 T790M mutation positive, and Osimertinib was started, 7 months, partial response. Unfortunately, after 7 months liver progression, we decided to do a liver biopsy, persistence of exon 21 T790M, and we really were very surprised when we saw the positivity of the patient was ALK positive by immunohistochemistry that we confirmed with FIS. At this time, we started alectinib, but to tell you the truth, the experience was really bad. The patient died after 15 days receiving alectinib. So we don't know if we should combine osimertinib plus alectinib. The truth is that we didn't have enough time. In 15 days, the patient have died. And I think this is, okay, the last slide. I think we are living in relevant moment. I'm really excited with the moment. I really enjoy the moment we are living, my daily practice. I am learning a lot, and I think it's nice after 25 years doing practice that we can enjoy and we can learn. And when we talk about precision medicine, I truly believe that the best is yet to come. Many thanks for your kind attention.
Thank you so much, ma'am. We'll move on to our next talk. The topic for the talk is real-world evidence, Osimertinib as SOC in the management of EGFR mutant non-small cell lung cancer. And our speaker is Dr. Vishwanath S, consultant medical oncologist at Apollo Hospitals, Bangalore. Over to you, sir.
Yeah. Thank you so much, Kashish. Thank you, organizers, and thank you, AstraZeneca, for this opportunity. Yeah. So my topic for today is real-world evidence. Osimertinib was as standard of care in the management of EGFR mutated advanced non-small cell lung cancer. So in patients with EGFR mutations, PFS improves after treatment with EGFR TKIs compared with the cytotoxic chemotherapy. And Osimertinib, as we know, is the irreversible third generation TKI, demonstrated a clinically meaningful survival in the progression-free survival of 18.9 months versus 10.2 months in the FLORA trial, and the hazard ratio was very impressive at 0.46. And the overall survival, which was presented by Ramalingam and colleagues, also showed that the overall survival was 38.6 months versus 31.8 months. Again, an impressive hazard ratio of 0.8, and definitely has made Osimertinib the best option for these patients. So this is a brief description of the FLORA trial, which Dr. Rosario also alluded to. So the final OS survival. So the FLORA trial, this is the inclusion criteria: patients 18 years or over and good performance status, exon 19 deletion or the L858R, and no prior systemic anti-cancer therapy, and stable CNS metastasis was allowed. And patients were stratified again based on Asian or non-Asian ethnicity and the exon 19 deletion or the L858R, and patients were randomized to Osimertinib versus comparator arm of Gefitinib or Erlotinib, and subsequent follow-up was done, and the PFS was the primary endpoint and the overall survival was the secondary endpoint. At the end of data cutoff, around 22% of the patients in the Osimertinib arm and 5% in the comparator arm were still ongoing with the study treatment. And this is the baseline characteristics, which Dr. Rosario also alluded to. And here, the most important thing you have to understand is that 19% of the patients had CNS metastasis at baseline. And if you see, Asian ethnicity was almost 62% in the Osimertinib arm. And there was also 63% of the patients included the exon 19 deletion, and 37% were having the L858R mutation. And you can see very impressive early separation of curves, like the previous speaker mentioned. And you can see that the PFS, the subgroup analysis shows that in every aspect, the Osimertinib was a true winner. And definitely the PFS was significantly prolonged in this subset. And here goes the final OS benefit. And again, a 0.8 hazard ratio. And you can see again that significant number of patients were actually even alive at 54 months, you can see here. So based on all this, the NCCN guidelines does say that Osimertinib is the preferred option in patients who are having upfront EGFR mutation or who are on systemic therapy and EGFR mutation is detected during the first-line systemic therapy, where Osimertinib is the option. So now going on to the real-world evidence of Osimertinib, there are 3 studies: the FLOWER study, the OCFAC study, and the Mykonos study. And this first one is the FLOWER study, which is the first-line Osimertinib in these patients. And as we know, this is the introduction. The background is from the FLORA trial. And it has been estimated that only 2 to 4% of the patients with cancer receive treatment within randomized controlled trials, thus raising the issue of the representativeness. Hence, real-world data has become a useful tool to assess unique insights in routine oncology practice in post-marketing setting. So this is the baseline characteristics of the study. It was an Italian study from 9 oncology centers, 126 patients. The median age was 68 years. And most of them, as understandable, were adenocarcinoma. And 38 patients, so 30% of the patients included brain metastasis. And you can see that 50% included exon 19 deletion. And you can also see that around 12.7% of the patients had an ECOG performance status of 2 or more. So this is the inclusion criteria, which has been talked about previously. And also they looked at another endpoint, which was the time to treatment discontinuation. So median time to discontinuation was one of the primary endpoints, and also the treatment-related adverse effects and the rate of dose reduction and temporary or definitive treatment interruption due to adverse effects were all considered as the primary endpoint, and all the usual secondary endpoint, and PFS here became the secondary endpoint. And they also looked at something called diagnostic therapeutic pathway, that is a time between diagnostic biopsy and histological report, and the proportion of patients receiving loco-regional treatment, and also at the time of disease progression, what was the type and frequency of rebiopsy, etc. So this is the primary primary assessment, the effectiveness. And what you can see here is that patients with poor performance status, comorbidities, rare EGFR mutations, and also active brain metastasis were included which was specifically excluded in the FLORA trial, and the outcomes were similar to published data, thus adding consistency to the osimertinib efficacy. And most importantly, there was no difference in the PFS or time to treatment discontinuation and OS in these subgroup of patients who are elderly or who are having comorbidities and those with lesser common EGFR mutations. So this goes to say that this drug is also effective in this population. And this is the time to treatment discontinuation, which was the median was 25.3 months. And in the FLORA trial, it was 20 months. And here it goes to say it's as understandable that patients who had symptoms had time to discontinuation of around 18.8 months, the median, and it was not reached in patients who were asymptomatic. And again, those between oligometastatic and patients who had 3 or more metastases, you can see that patients who had oligometastatic disease, the progression-free survival was better. I mean, time to discontinuation was better. So definitely, the time to discontinuation was more, 25.3 months versus 20.8 months in the FLORA trial, and patients who had oligometastatic disease or those who are asymptomatic did better. So again, they also looked at patients with the symptoms. We just spoke about this, oligometastatic. This is again, patients who had brain metastasis did badly as compared to those who did not. So the median progression-free survival was 18.9 months, which was quite similar to the FLORA trial. And this is again a repetition of the same thing. And the OS was not reached at the time of data cutoff. And patients who had time to discontinuation of 9 months or more was significantly associated with better OS. So definitely they also looked at this diagnostic therapeutic pathway. And among patients who had progressive disease, 47.7% underwent a rebiopsy at progression, and tissue rebiopsy in 14 cases, that is 66.7% of the cases, and liquid biopsy in 28.6% of the cases. And subsequently, like the previous speaker mentioned, there's other mutations like MET amplification, EGFR amplification, HER2 amplification were also seen in these patients. So safety data and conclusion. So definitely it goes to say that the safety data was quite similar to the FLORA trial, except that these patients, they found that the venous thromboembolism, including the grade 3, grade 4, which was only around 3 to 4% in the FLORA trial, here it was close to 8%. And if you include the grade 1, grade 2, plus the grade 3, grade 4, it was significant. Venous thromboembolism was seen in this particular study. And most importantly, no difference in the rate of venous thromboembolism was reported even if the patient was elderly, having poor performance status or comorbid disease, or had a high tumor load. So this is the summary which we have spoken about in detail. And going to the next study, which is the OSIFACT study. And this is the background. So again, patients who had advanced EGFR positive non-small cell lung cancer with osimertinib as the initial treatment were included, and patients who were concurrently on other anti-cancer therapy or were receiving radiation therapy were excluded, and those undergoing post-operative adjuvant chemotherapy or those receiving osimertinib in the second-line treatment were all excluded from the study. And here is the baseline characteristics. And what you can see here is that they included 538 patients, a large number of patients. And this was the Japanese study. And you can see that several of them, also close to almost 15 to 16% of the patients had ECOG performance status of 2 or more. And you can see that around 50% of the patients had exon 19 deletion, and 45.4% had the L858R mutation. And also they stratified based on the PDL1 status. And you can see that those who had 50% or more of PDL1 status were close to 12%, and 1 to 49% of 31.6%, and less than 1% of 30%, and 26.6% had unknown PDL1 status. And again, if you add up the asymptomatic and symptomatic brain mets, again, 30% of them had brain metastasis, which was higher than around 20%, which was seen in the FLORA trial. And what was the study endpoint? It was the primary was the PFS, and the secondary endpoint was the OS, and the other usual endpoints, including the treatment failure. And the efficacy analysis, PFS events occurred in 182 out of 538 patients. The median PFS was 20.5 months. And you can see this is the median PFS, again, little more than the FLORA trial data. And what parameters were associated with the reduced PFS? Patients who were males, had malignant diffusion, had liver metastasis, and advanced unresectable disease. These patients had a poorer PFS as compared to those who were not having this variables. And with respect to PD-L1 expression, again, the median PFS was not reached in those with a TPS score of less than 1 and 14.7 months between of less than 49% TPS score, 11.1 months for those with TPS score of 50%, and it was not reached in patients with TPS score of unknown. So you can see that the higher PD-L1 was associated with a reduction in the PFS. This is the same thing which is alluding to that. And what was also interesting to note that the incidence of pneumonitis was significantly higher in this particular study. So you can see that in this Japanese study, 25.6%, 1/4 of the patients had pneumonitis. And you can see that 44 that was actually one of the more important reasons for also the treatment discontinuation. And apart from the most common reason, of course, disease progression, and 16% was attributable to other side effects, and the other reasons like not compliant patients and patients' request and doctor's judgment, comprising the rest of the 14 to 15% of the patients. So to conclude, the overall response rate in this particular study was 76.2%, and the disease control rate was also quite good at 94.1%. The PF was better in the Osimertinib as compared to the conventional TKI, and irrespective of the PD-L1, but higher PD-L1 was associated with the reduced PFS. And the median time to failure was 19.1 months, and the median time from the start of treatment to the onset of adverse effects was 56 days. And pneumonitis of all grades was higher as compared to the FLORA trial. So definitely, I think this pneumonitis is something which requires further investigation. And so this is the summary. And coming to the last study, which was published in Journal of Thoracic Oncology by Neva et al. And this again is the background which we have discussed in great detail. And this study reports the demographic and clinical characteristics. And they looked at again some interesting endpoints, which was real world time to next treatment or discontinuation, and real world time to next treatment or discontinuation. Yeah. So this was a global observational prospective study going on in the US, Europe, and Asia. And this was an interim analysis. The data was collected through 30th June 2020. And this was a sub-analysis which included data from the Flatiron Health electronic record. And the study is ongoing, and they're also planning to the follow-up till 2023. And here they included inclusion criteria of 18 years or more, and the stage 3B, stage 4 non-small cell lung cancer, the documented EGFR mutation, and the Osimertinib was initiated from 1st April 2018 to March 31st, 2020. And they also included patients who were in earlier stages of disease, but who had progressed to stage 3, to stage 4 when they had started collection. So this is the different endpoints, mainly the real world time to treatment discontinuation and real world time to next treatment or death. So what you can see here is the baseline characteristics. It did include around 14% of patients who were Asians. And also important to note that again here, around 15% of the patients had a performance status of 2 or more. This was not there in the FLORA trial. FLORA trial mainly included performance status 0 to 1. And again, you can see that 33.6% of the patients had evidence of baseline brain metastasis. And of course, 22.1% it was unknown or assessment was unavailable. So again, there was a substratification. The EGFR exon 19 deletion was seen in 51.1% of the patients, and the L858R in 33.7% of the patients. And at the interim analysis, 58% remained on first-line Osimertinib therapy or were lost to follow-up, and 18.8% received second-line treatments, which included PD-1 or PD-L1 mono or combination therapies, or it could be EGFR TKI monotherapy and combination therapy, and sometimes even chemotherapy. And 18.4% of the patients died while on first-line treatment, and 4.7% of the patient discontinued first-line treatment. So very small amount of discontinuation rates. So you can see here that real-world time to next treatment or death, you can see that it was 17.9 months. And you can also see here, this is the median. And the other endpoint was the real-world time to next treatment or death. And again, you can see that there were some certain indicators, variables, which meant that these patients could do badly. That is the stage, of course, smoking status, comorbidity index, and EGFR mutation type, and also the number of metastases of at least 4 or more. And similar thing was also seen with real-world time to treatment discontinuation, similar median of 17.2 months. Again, similar variables which could predict that these patients could do badly. So take-home messages, this study again proves that real-world insights into the first-line osimertinib in patients with advanced EGFR mutated non-small cell lung cancer based on the first data cut analysis of the US subpopulation. And this interim with interesting endpoints results supports the effectiveness of osimertinib in this real-world population, and long-term outcomes will be evaluated in the final analysis, as this is the interim analysis. And this is the summary which we spoke about. And thank you so much for a patient listening.
Thank you so much, sir. We'll now move on to the panel discussion. The panel discussion will be on the topic management of metastatic EGFR mutant non-small cell lung cancer. Our moderator is Dr. Ullas Batra, Co-Director, Department of Medical Oncology. He's also the Chief of Thoracic Medical Services at Rajiv Gandhi Cancer Institute and Research Center, Delhi. His panelists are Dr. Unni S. Pillai, Senior Oncologist, Dr. Jyoti Wadhwa, Dr. Jatin Sarin, Dr. Rosario Garcia Campelo. Dr. Sandeep Ganguly is actually stuck in an emergency, and so we'll let you know once he joins. Over to you, sir.
Thank you. And can I also have Dr. Shyam Aggarwal and Dr. Vishwanathan? The more the merrier for the moderation.
Yes, sir.
Okay, Vishwanath is there. Fantastic. Dr. Shyam Aggarwal, sir. Okay, we will let him be when it comes over there. So thank you, and it was great listening to you, Dr. Rosario. And we will talk about the real-world conundrums in treating EGFR mutant non-small cell lung cancer. And my first reactions when I actually saw this topic was one of boring. I mean, EGFR mutant non-small cell lung cancer, even if you look at Vishwanath right now, he's bored. He's like, why are we even discussing this? We all know what it is, an Astra symposium. We're going to do something else. We're all going to say something. So, it's boring. My subsequent reactions when I thought about EGFR mutant non-small cell cancer was this. This basically says, Aaj kuch toofani karte hain. And for Dr. Rosario, that basically means that let's do something wild today. Anyway, it's a Friday evening. So in the course of next 20 minutes, let's do something wild. Let's just, let's not think about, let's just keep the Astra people away from this symposium, and let's just answer whatever comes to our mind and what we do in our clinical practice. Jyoti, are you Dr. Jyoti? Dr. Jyoti is there. I can see her. And Jatin is there. Hi, and Dr. One is there. Fine. Great. So Dr. Jatin, your comments on this?
Yeah, I mean, you've chosen me first to do something wild. So
yeah.
what kind of comments do you expect from me?
You have, okay, let me ask you. What's the wildest thing you have done with an EGFR mutant patient? Dr. Rosario spoke about alectinib and osimertinib. What are the wildest thing you have done about an EGFR mutant patient?
I don't get that much of patience to do something wild. So I preferably stick to the standard of care if I am able to offer the standard of care.
I will at the end of it, I'll tell you what is the one wild stupid thing that I have done actually. I was not aware at that time. Dr. Jyoti?
No, I stick to the guidelines in my practice.
I know, Dr. Jyoti.
Nothing wild till date.
Gold medalist people from AIMS do not sitting in Medanta.
Not allowed to do wild things yet.
Not allowed to do wild things. Fantastic. Dr. Onni? You're muted, yeah. Dr. Pillai, you're muted. Dr. Pillai, you'll have to unmute yourself. I think there's some trouble. Kashish, can you help him out with that? Dr. Vishwanath?
Yeah, nothing wild that I can think of. The usual
no, I mean, I don't mean wild in the sense wild, some decision which you have thought which has backfired onto you. That's what I'm asking. Okay, no. So Dr. Rosario.
I don't know if I understood very well what the question. Okay.
The question is, what is something out of box that you have done for an EGFR mutant non-small cell lung cancer patient? Not making the patient sit on this thing, but something else that you have done.
Well, I saw you 2 cases that I tried to do things according to the biology of the disease. The truth is that in one of them, the result was really poor. I try to think differently for every single case, but from the very beginning, what I can offer is standard of care, guidelines, or whatever clinical trial I have available. But I try to do different things when I have an EGFR mutant or an ALK translocated or whatever other genetic alteration in my patients, when I can find something that I can do different. I don't know if I answered you.
So yes, you did. And so I'll tell you an honest confession about what is an out-of-box thinking, which later on became very wild and stupid and had egg on my face. That was the early days of Osimertinib and the immunotherapy. And we were trying to give, we gave a patient EGFR TKIs. It was an uncommon mutation. So we gave Afatinib to start with. And then we gave, then the patient progressed and we wanted to try the ABCP. We gave Osimertinib and we gave ABCP. And then we were thinking in terms of giving Osimertinib. So immediately after 2 to 3 cycles of this, without waiting for a washout period of immunotherapy, we did give the patient immunotherapy, and that was not wild, that was bad. The patient did develop the drug-induced pneumonitis, and I did take a very, conscious decision to have a washout period. And if you, Dr.
I think you have raised a very, very relevant topic, and we have a recent case very similar, Osimertinib. Then we offer a clinical trial with chemotherapy plus immunotherapy. The result was really poor. And we detected in a liquid biopsy a C797X mutation. We offered gefitinib after that chemo plus immuno, and it was terrible. We achieved, the patient achieved an impressive radiological response with gefitinib, but the patient developed a pneumonitis, a severe pneumonitis. I told my residents and the young people of the team, be careful. Be careful when we use immunotherapy. Now we have these potential options of doing sequencing approaches according to the resistance mechanism. Be careful with immunotherapy in this patient population. This is the lesson I learned from this case.
And the second thing which I didn't do, which somebody else did, was there was a PDL1 90% patient, and EGFR was negative by a single gene assay, and ALK was negative, and they again got a single agent immunotherapy. We got an NGS done. It came as an uncommon mutation because that particular mutation was missed in that small panel. And then I was in a soup because the patient already got 2 cycles of Pembro. And if you really go by the trials, I'm sure Dr. Jyoti will agree, you actually have to wait for 2 to 3 months for the washout to occur because the T-half of immunotherapy is high. So, we did give them 1 or 2 cycles of chemotherapy and then put them onto Osimertinib. So one very important thing is that, we need to be very careful with immunotherapy because once it is given, it's a commitment. It's a commitment. That's the first thing that I have done.
Fully agree.
Yeah. The third thing, Dr. Rosario, in fact, we have a published paper of Osimertinib and Alectinib, and our patient actually had leptomeningeal mets on initially Afatinib, then Osimertinib, then we gave OC plus Alectinib. We have published that into the clinic lung cancer, and the patient's PFS was around 8 months, and the brain mets responded beautifully. So we were pretty lucky actually in that. So that was
nice case.
Yeah. So let's start with the normal cases now. And we have a 60-year-old female. A PET scan done shows up stage 4 lung cancer. The lab parameters were normal. The biopsy shows adenocarcinoma. So very standard question. Vishwanath, let me just ask you, you sound bored. What will you do? What will you do? How do you approach turnaround time in your situation? We'll ask everyone. Everybody comes from a different setup. Bangalore, Punjab, Medicity, and abroad. Let's ask what everybody does.
So yeah, so generally I start with this, the conventional EGFR, ALK, and ROS1. I do all three of them. And I start with the timelines for EGFR, ALK, and ROS1 is generally 1 week for us. 1 week to 10 days at the max.
The biopsy will take 4 days or 5 days, or how does it go?
So the biopsy in our center at Apollo Bangalore is quite quick. It's very quick. Almost in 2 days we get the biopsy report.
Okay.
So it's in
2 to 3 days biopsy report, 7 days EGFR ALK. So in 10 days time, you have, and do you start chemotherapy? What percentage of people do you start chemo? You do.
So I start chemo. I send EGFR ALK and ROS1 and I start chemo.
1 cycle.
I actually follow, if EGFR comes positive, I actually add I continue with the chemo as well, but not
TMH, but with TMH regimen.
The TMH regimen. Yeah.
Okay, Dr. Pillai. Dr. Oni Pillai. Hi. So what do you do?
Sir, sir, can you repeat the question one more time?
Yeah. So you have a stage 4 non-small cell lung cancer patient. The biopsy has come as adenocarcinoma. What is the path you follow for doing the molecular testing?
So we use the coupon. We have a 12-gene coupon from
the coupon testing. Okay.
Yeah.
For benefit of Dr. Rosario, I will tell her the coupon scan later. Okay. So what time do you get the report, Dr. Pillai?
In 14 working days, sir.
In 14 working days, which is approximately 18 days. And do you give 1 cycle of chemotherapy prior?
If the patient is fit enough, no, sir. No, we would not give.
Patient is fit enough, no. You and the patients are willing to wait. They don't jump to any other oncologist.
That's okay, sir. We have a good case, so you don't worry.
Okay, you don't worry about that. Okay, let me ask Dr. Jatin.
Well, in this case scenario with this much disease
Dr.
load,
Jatin, can I just interrupt you for saying? Let's say it is the election season in Punjab. So what do you do in the pre-election season and the post-election season? Just joking.
No, I won't vary my practice with that. Anyways, the only thing is, yes, we tend to send for the relevant biomarkers, but in this very particular case, with this much of disease load, I would really like to start on chemotherapy.
Yeah. And routinely you send for NGS or a single gene biomarker testing?
Preferably NGS, if I can.
Approximately what percentage of your patients will take an NGS and what percentage will take a single gene scan?
Well, it used to be 20 to 30% only which went for NGS and rest of them for individual genes.
Okay.
But gradually these things, they are not getting converted. Especially that the coupon thing has really helped.
Okay. For the benefit of Dr. Rosario, there is a industry-sponsored a coupon in which the patients get a 12 gene testing done. It's a small lung CA panel, but the problem is they do only a DNA-based testing. They don't do RNA. So you do not get that reliable results from the RNA point of view. Yeah. But that's the way it is. It's free, and they, as Dr. Vishwanath said, you get the results in 14 days time. But now let me turn my attention to Dr. Jyoti Wadhwa, who is in one of the most posh institutes of our NCR Delhi region. So Dr. Jyoti, what do you do?
So in this case, I would order broad panel NGS, and I'm happy to share with you all that we have now started doing 21 gene panel NGS in-house. And the result does become available in 2 weeks. And earlier, I have also used the coupons and ordered 12 gene panel. And before that, we also have done limited testing, doing just 5 tests, the chosen ones in our patients. When we would get the report, as soon as we get, say, EGFR first or ALK first, we start the treatment if any of them is positive. And I would also order MRI brain in this patient.
Yes, MRI brain, definitely, yes. Dr. Rosario, what is the scenario there?
Yeah, I miss the smoking habit of this patient.
Non-smoker.
Okay, no smoker. We do a panel and we get the results in around 5 to 7 days. So we try to wait for the molecular analysis before starting any kind of systemic therapy. If the patient is really symptomatic, we can do a liquid biopsy. We do COBAS testing just for EGFR. And, you know, because sometimes we detected this alteration and we get the results in 24 hours. But we try to wait for the molecular results before starting the treatment. And if the patient is a never smoker, if I don't have the results, I used to avoid the immunotherapy. If I have to start something systemic, I prefer platinum doublet without immunotherapy and wait the molecular results before introducing the immunotherapy approach.
So, Dr. Rosario, there is a question in the panel, in the chat box, which says, what is the minimum number or maximum number of genes that you test for? You said you get the report within 7 days. So it's a small panel of gene testing that you do, or?
Yeah, we have a panel in-house with 32 genes, I guess.
Okay.
But we are in the process, and I have been told yesterday that before the end of the month, we are adopting a very huge panel with more than 400 genes. My understanding and what I have discussed with the pathology department is that we don't need this huge panel for every single patient. We can manage our daily practice with the small panel, and we are going to use this new panel for those patients we don't detect anything in the common one, or for special cases at the time of recurrence to detect a specific resistance mechanism. So we are moving, we are in a transition process. We have a small one. We have also access to more than 360 and to foundation panel in selective cases. I am the one who says yes or not according to the clinical characteristics. So I think we are lucky. I think we are lucky.
Yeah. Dr. Rosario, so what I get to understand is you will use a small gene panel for your daily practice.
Yes.
If something comes out of it, doesn't come out of it, maybe when you're looking for a resistance, you will do a large panel. That is what
exactly. Exactly.
And you are going to get the report in 7 days time. That's huge.
Yeah. This is what the panel we use now, we get the result in a week time. Yes.
Yeah. Wow, that's fantastic. So, Dr. Jyoti, this question goes to you. You know, there's a lot of story, not in Astra symposium, but in Pfizer and Lilly symposium about the co-mutations. I'm sure that since you are using all the, since you're using NGS now for everyone, what if you get co-mutations? I mean, what would you do? Will your choice of treatment change, or what will happen then?
So till now, since we used to get, sequential reports, so I have had patients whom we started with EGFR targeted treatment and then added on another ALK inhibitor or something. But now you are right that with more broad panel NGS, we are likely to encounter this co-mutation issue more and more. The reported incidence is about 3 to 4%, I think. But let's see what we see. Yeah, in our experience, we haven't, as I said, we have just started doing in-house. So let's see.
I am not talking about the EGFR ALK, I'm saying EGFR with other co-mutations, So
if I encounter that now, as we heard Dr. Rosario also share that, if we find something which portends poorer prognosis, say TP53 or PIK3CA mutations, I might consider adding, say, chemotherapy to the first-line TKI. So at least I'll discuss, that option. So we know that the current standard of care would be TKI. The combination is not yet part of any standard guidelines, but I would definitely bring out this issue in discussion with the patient, the implication of the additional mutation detected.
So Vishwanath, I wanted to ask you, do you think these co-mutations are a poor prognostic factor, or they are a predictive factor towards a EGFR TKI combo or a, the BEV combo or a, second generation TKI? What's your thoughts on that? I'm sure nobody has a right answer for this, honestly.
I think both are right answers. It can be both predictive as well as prognostic thing. Like Dr. Jyoti did allude to, that P53 could be poor prognostic. And again, it could also be predictive. So
will you change your treatment regimen? That's what I'm asking, because, slowly but surely, I'm sure the entire India in next 3 years time, we are going to go to NGS for everyone in lung cancer. I'm very sure of that. So, are we going to change, saying that, okay, maybe Osimertinib, the third generation TKI or a TKI alone is not a good drug? There's no data that, not that I am aware of, that, the TKI chemo combo will take care of that. I'm not sure. So is it a prognostic or a predictive factor? That's what I meant by Tufani Karte Hain.
So what I may do is, till we get the FLORA2 data out, we may just go ahead with the conventional TKIs, the Gefitinib or Erlotinib, Gefitinib with the chemo in these kind of subsets,
okay,
but not Osimertinib plus chemo.
Till the time you await the FLORA2.
FLORA2.
Okay.
I think there was some paper from TMH only, if I remember correctly, that did mention that they did report PIK3CA mutation, co-mutation. They did report that, addition of chemo to Gefitinib did make a difference, and they would definitely suggest the additional chemo.
Yeah, but the point is, this has not really been compared. My point here is, and the point here is, it is a poor prognostic factor, we know. But in the absence of a head-to-head comparison trial between, OC or a FLORA2 study with showing this, I am not so sure we should be, because my point is, you start somebody, on what basis are we saying that OC is not working? I would any day want to avoid chemotherapy for any of my lung cancer patients for as much as we can. That's my take on that. Dr. Jatin, your take, and Dr. Pillai.
Well, yeah, as we go on to do more and more of NGS, I think we might encounter co-mutations, although they are rarer in the present scenario. And yes, if the co-mutations are there, it is safer to go with some kind of combination with chemotherapy. Suppose you get rarely a KRAS mutation along with the EGFR mutation, there would be a efficacy of any TKI. So there are various examples this way. So I would agree with the other panelists, and I think Dr. Navneet showed a very good slide that in future they will get a report in which it will be a complete proteomic and genomic signature of a disease, and we'll have to customize our treatment according to that.
Okay, Dr. Rosario, I'm sure that chemo plus TKI combination is not approved in your country.
No.
So what do you do if you get co-mutations? And do you agree with this line of thinking? That's what I'm asking you.
Absolutely, I fully agree. The problem is that we cannot offer chemo plus tyrosine kinase inhibitor combination in the country. So when I have this situation, this is the patient I try to include in one of the trials we are running in the first line setting, to tell you. This is the patient I want to include in a trial with a combination approach, because probably these are those patients who are getting the strongest benefit. I think we need more data. I am missing information today on this topic, because I think that from the real world scenario, we probably can get enough information or more information how these patients go in terms of potential places of recurrence. Is there any clinical parameters that can guide us in terms of making therapeutic choices? I miss information, and I try to include these patients in clinical trials that I have with combination approaches.
In fact, I was listening to Dr. Tony Mock's presentation in one of the symposiums, and he said liquid biopsy can be a very good tool. You start with Osimertinib for these people who do not, or any TKI for that matter, the people who do not clear their EGFR mutation by, let's say, 3 or 6 months. And we have also shown in our, in our dynamic study, and everybody FLORA2 subset was there, that these are the patients maybe you can be used to select giving chemotherapy in addition to, or maybe, you should accelerate or aggravate their treatment regimen. So to me, the answer
Absolutely.
for them
The
is
signal is the same we have seen in the ALK scenario with the new agents. It's the same with Lorlatinib, it's the same with Brigatinib. So you have this clearance and you can try to define who are those patients who are not getting the strongest benefit from the approach that you are using. So try to do something new because it's clearly it's not the way to move forward. So
maybe the idea is that we can do a BCR ABL, you know, what you do in CML. If your patient does not achieve a quantitative 0 test by 6 months or 8 months, probably this is the time that maybe he may not do well, he or she may not do well, and then change the therapy. That's the way I envisage the future of lung cancer treatment and liquid biopsy to come into that. Coming on to the score of Tufani, Dr. Pillai, are you still there? Yeah. So what about liquid biopsy? How many patients of liquid biopsy have you ordered? And do you routinely do liquid biopsy NGS in these patients?
Yes, sir. Sometimes, not very often, but when they probably fail on one kind of TKI. Am I mute?
No, we can hear you loud and clear.
Okay, so we used to we very seldom, very few patients do liquid biopsy upfront. Most of the time, our molecular test will be done on the solid specimen.
Okay.
But after 2 or 3 biopsies, if we don't have an adequate specimen, we do offer them a liquid biopsy. But we routinely do liquid biopsy or for someone who has progressed on first-line TK.
Okay, Dr. Jatin, liquid biopsy?
Yeah, most of the time when there is a progression on first-line TKI, but in some cases, as rightly said, if the patient is not willing for biopsy, very adamant to even undergo an FNAC, so that we cannot make even a cell block, then we may send liquid biopsy by NGS, but the percentage is very, very low, rarely.
Okay, Vishwanath and then Dr. Jyoti.
Yeah, I would be very reluctant to treat based on liquid biopsy. So upfront, I'm not very keen on doing it.
Okay, fair. Dr. Jyoti?
Yeah, rarely. So theoretically, yes, it's an option in a very frail, very sick patient who's unfit to undergo invasive tissue biopsy. One could consider somebody who has, metastatic site as only bone, wherein it could be very painful and traumatizing. One could consider, but more often its use is in progression after first-line treatment and rarely in the first time.
So, Dr. Rosario,
yeah,
Umberto, Cristiano Ralfo, Natasha Lee, they're going all over the town saying liquid biopsy, liquid first. What is your statement? What do you think? What do you practice?
Yeah, I am fully agree with the last panelist. I think that Dr. Jyoti, I think that in some cases, liquid biopsy can be very useful at the very beginning. Those cases who you don't have enough tumor material, patient is not in a clinical situation for doing a biopsy. We do liquid biopsy in those patients. It's true that our experience is low, but patients, when you get the result, the outcome with the targeted agent is the patient responds. So you can trust that result. We use it. And we use overall in terms of progressive disease. But I think it's a very useful tool.
Okay.
And it's going to be even more useful in the future.
I think we have only 5 more minutes. Let's come to the meat of the matter. PS1, ECOG PS1, EGFR del19 present, no co-mutations. Okay, let me just change it. EGFR L858R, let's just have some fun. EGFR L858R, young 45-year-old male. Vishwanath, what would your choice be? PS1.
Yeah, see, I would go with Osimertinib, but the data is 14.4 months. It's lesser, but
you
still.
Don't have to be apologetic towards going with Osimertinib, Vishwanath. It's okay.
Yeah, so yeah, definitely Osimertinib.
So EGFR L858R, Asian, PS1, Osimertinib. Okay. Dr. Jatin?
Well, looking at the data and all, suppose in this case already we have started with chemotherapy, then I would go with the Tata regime, Pemetrexate, chemo with the Jeftinib.
Okay, let's say you have not started chemotherapy. Let's just say you have not started chemotherapy.
Okay, in that case, yeah, Osimertinib is one this thing, and other I can go for with the Dacometinib.
Okay, so you would want to go for Dacometinib also. You can also have an option because of the subset analysis of the FLORA trial, which you probably are referring to.
Yeah.
Okay, Dr. Jyoti.
So Osimertinib would be my preferred choice if no financial constraints, but Dacometinib would be my next choice.
Osimertinib followed by Dr. Pillai. You're muted again, Dr. Pillai.
Sir, can I request you to remove the earphones? Maybe we're not able to hear you.
Dr. Pillai, your earphones, what is happening there? Kashish is able to hear, but you are not able to hear. Take off the earphones at least.
Okay, so my choice will be Osimertinib.
Okay, Osimertinib. So we have 3 Osimertinibs, 1 maybe Dacometinib. Madam, what is your take?
Me?
Dr. Rosario, yes.
Yeah,
Osimertinib. So
yeah,
the subset analysis, that is what I wanted to ask you. You know, there are a lot of debate about the L858R Asian subset analysis. It doesn't really bother you?
No.
Okay. Okay. And I just wanted to, I mean, this is just something which basically shows there are many options available for all the patients available, but I think Osimertinib is absolutely okay. Let me just come to the pros and cons of Osimertinib. It's a well tolerable, increased PFS, increased OFS, crosses the blood-brain barrier, but we don't know what to do at progression. The Asian subgroup, the L858R, the cost of that. And what I'll ask you, Dr. Rosario, now in the last 3 minutes is, do you always rebiopsy after Osimertinib progression?
I always try to do a biopsy. If I can't, I do a liquid biopsy. Yes.
And what has your results been?
Okay. We have included some patients in the ORCA trial, patients with MET amplification. We have 2 patients included in the ORCA trial. Also, we have included patients in a trial with immunotherapy because nothing was found. And then in these 2 cases I showed to you, we detected this C797S mutation and the exon 14 mutation. So I think it's not the standard of care, but if you can, I strongly recommend.
So we have, in fact, we also have 2 trials going on, the same, the Savannah study in which we are giving Osimertinib plus Capmatinib, and we have the Mariposa study in we have given Amivantamab and Lazertinib and the chemotherapy versus chemotherapy. So I think doing a biopsy and trying to find out is a very good idea. You spoke, and this is a very important thing which I want to show. The resistance mechanism to Osimertinib actually includes 40% MET amplification. And I don't think the Coupon scan actually looks at the MET amplification. So I think we should ask our people whether they do the MET amplification in that. So what I wanted to ask you, Dr. Rosario, and that's going to be last, this thing is, how do you manage the C797S resistance mechanism? Just a brief, you got it fine, fair enough. Yeah. Then what do you do?
Yeah, I saw you took one of the cases we treat with Gefitinib.
Yeah.
With Gefitinib, yeah, C797, and we offer this first generation EGFR tyrosine kinase inhibitor. And we don't have access to the 4th generation agents that are supposed to inhibit this kind of alteration. I think this is still at the very beginning of the process. I don't know what is your experience or what do you do in your practice?
So we had 2-3 cases of C797S. What's very important is, I mean, if you can read this paper, once you have C797S, look at the T790M. If you have T790M loss and you have a C797S, you can actually give them 1st and 2nd generation DKIs. If you have T790M present and you have the CIS in NSCLC, you can give the 4th generation, which is not available. But if you have the T790M present and C797 in trans, you can actually give them a combination of OC and GEFT. So, you know, I mean, this I read only some time back when my patient had a C797 in trans, and we have just started a patient on OC and Gefitinib based combination. So again, you know, it's important to do the biopsies, but it's more important to be able to read the NGS properly and do things like that, which is there.
I think that we need to since these are very rare and the clinical cases that we have are rare, we need to publish these experiences and to have more experience we can learn and we can get information from the published data. And real world data is going to be relevant because we are not doing trials for every single molecular alteration we detect after progression. So in order to get those drugs available, those drugs approved in our countries, we need to have very strong real world data. This is what I think.
Okay, so I have many questions, but I think that's my last question. Doctor, there are two questions over here which Dr. Parekh is asking, which says, when you mentioned young 45-year-old, are you saying there are unlikely to be significant comorbidities? Not really, sir. I am not saying that. I am saying if this patient had no comorbidities, so that's it. If you rebiopsy, will liquid biopsy be enough? That's the second question. Sir, my take on liquid biopsy for all the audience is very, very simple. If you get something in liquid biopsies, that's good enough. So let us say you get an ALK, you get a MET, or you get something. If your lab is good, if it's NABH aggregated, if your lab is good, if you get something in liquid biopsy, it's there. If you do not get something in liquid, so that basically means specificity is very, very high. The sensitivity is slightly lower than the tissue biopsy. So if I get an ALK rearrangement in my liquid biopsy, I'll be absolutely okay in treating them with the ALK TKIs. And there are a lot of studies, we had a symposium on liquid biopsy, this complete study, the Nile study, that we can actually use that over there. So I hope that answers your question. There are one more question which has been asked. Role of liquid biopsy in a patient on Erlotinib who returns after 2 years with increasing radiopacity, lung rebiopsy or liquid biopsy, which is the right choice? Again, I will like to answer that in the interest of time. I am a proponent of solid tissue biopsy also, because we only, Manojji, have got 8 patients of small cell transformation in lung cancer. So that is one thing which I would like to rule out. If the patient is absolutely not insisting on, is reluctant to get a liquid tissue biopsy, I'll go for liquid biopsy. Otherwise, tissue biopsy can be tried, just to rule out a small cell lung cancer transformation. Dr. Rosario, your comments on that?
Yeah, I absolutely agree. I think that if you get something from liquid biopsy is enough, but if you don't, you should confirm. And also, I think you need to consider the kind of progression. If you get a bulky mediastinal nodes, that can suggest that this patient has a small cell lung cancer transformation, or even if you get in the liquid biopsy a retinoblastoma alteration, you may think that this patient has transformed into a small cell lung cancer. So also clinical information, radiological information can give you some clues.
Yep. Is there any other point in the panelists would like to discuss? If not, we will hand it back to the organizers and we'll stop. So any other point that Dr. Jyoti or Dr. Jatin wants to clarify? Dr. Vishwanath, another point.
So in one of the cases, you did mention that the PD-L1 was 90% by 22C3. So this question is to you and Dr. Rosario. Would that make any difference? Because they say that high PD-L1, lower PFS. So
absolutely no. So we have published literature, Vishwanath. I didn't show it over here. We have published literature. We have compared the efficacy of first and second generation TKIs with regards to PD-L1. Absolutely no difference. So the only thing with PD-L1 which tell me is do not give immunotherapy without getting the biomarker result. That's the only thing which I will do. I mean, I'm fully agree. My only job in my clinic is to prevent my juniors from giving immunotherapy to a PD-L1 90% without getting an NGS report. Dr. Jyoti, your final comments on anything?
No, fully agreed with you on that. We have to be careful, we have to rule out any driver mutation before we jump on to give immunotherapy.
Dr. Jatin is obviously reading that it's a good discussion, clarify many points. So I think that was my last question. And I think we'll hand it back to the organizers. Thank you. Thank you all the panelists for being a sport and had a great mind learning. Thank you, Dr. Rosario. And I hope everybody's safe and we all hope to see everybody soon in the physical way, in the offline mode now. Thank you.
Thank you.
Many thanks.
Thank you so much, sir. Thank you to all 3 speakers and thank you to the panelists as well. Ullas, sir, can I request you to give we'll request you to give the closing remarks, and then
Sure.
we'll end for the
I think the management of EGFR mutant non-small cell lung cancer, I would say it took a 90-degree turn with the IPASS trial when Tony Mark presented the Gefitinib data versus Paclitaxel. It took another 90-degree turn with the advent of Afatinib and Dacometinib and Osimertinib. But now I think it's very exciting and very interesting to see all the way lung cancer is moving with other personalized therapy. I truly believe that NGS for everybody in lung cancer is going to be a scenario. We now need to be very knowledgeable about how to interpret an NGS report, because more important than not, a lot of in India, a lot of companies will come and tell, I am the best, mine is the best, this is the best. As medical oncologists, we do need to understand the nuances of NGS, which is very, very important. Having said about the diagnostics, I think liquid biopsy is here to stay. Liquid biopsy is almost what I say like Donald Trump. Whether you like him or you hate him, you can't ignore it. That is true. In the therapeutics way, I think Osimertinib, if the cost can be managed properly, I think it is heads and shoulders away above anything in lung cancer right now. Whether in stage 1, 2, you have the ADAURA trial, in stage 3, you have the LAURA trial coming up, in the stage 4, obviously FLORA. The cost is an issue. The drug is fantastic. And for me, the biggest point of Osimertinib is the CNS penetration rate. You avoid a brain mets for a patient, and that's a fantastic, because brain mets is a devastating disease. But we need to remember that Osimertinib is not, EGFR mutant survival is only 38 to 40 months. We want to go to a 7 to 10 year survival as we are going into LX. So we need to find partners for Osimertinib. And that is what all the literature and all the search of partners upfront, partners about how to manage resistance mechanisms to Osimertinib. And I'm sure with the clinical trials going on, things are there where we will have a lung cancer survivor meeting in an offline mode. With this, thank you. Thank you all the speakers and all the panelists for a wonderful discussion. Thank you.
Thanks.
Thank you so much, sir. Once again, we thank our sponsors, AstraZeneca and MedGenome, for organizing this webinar. With that, we come close to the session, and we hope to see you again. Goodbye, sir. Goodbye, ma'am.
Physically.
Bye.
Bye.